So when it comes to kidney is a very delicate area of histopathology, and so I'll just say sorry for the artifacts that we see. This is it is a very old slide, so bear with it. And so we have this capillary loops that form the glomeruli, right? And around the glomeruli, we have the proximal convoluted tubules with both granular cytoplasm and brush border, which if you can see, I'll try to highlight this in the lumen. Is the brush border, which is lost in acute tubular necrosis, first thing to be lost. Right. Then we have the third compartment, the interstitium, followed by the blood vessels. In either way, generally we comment upon like first the glomeruli, then the tubular system, then the blood vessels, and finally the interstitium. So in glomeruli, we first see the capillary loops, and before that we should know the parts. The first we have the capillary loops. In between the capillary loops, we have this pink looking area in the center, which is called mesangium. In mesangium, you can have 2 to 3 nuclei, which is normal for a mesangium, and the loops here are quite normal. They're quite loose, they're not stiff, and although it looks like a bit more cellular mesangium, but if you look carefully, I think there are not more than 2 to 3 cells per mesangial area. So I think that's fine. So what else we have? We have podocytes. Podocytes are generally the visceral epithelial layer of the Bowman's space. Now it faces towards the parietal layer, and it is generally seen, these podocytes are difficult to identify normally because they are seen on the periphery of the glomerulus and they face towards the parietal layer. Now, so what we do here, we will comment, first of all, we'll look at the basement membrane of the capillary loop and compare it with the basement membrane of a proximal convoluted tubule. So if it is more thick than this, we can say there is significant basement membrane thickening. And in such a case, we will have a more sieve-like glomerular capillaries. They will be stiffened, and we may see more prominent podocytes, which is known as lifting up of podocytes when we mention on a description. What else can we see? We can comment upon the mesangium, whether the mesangium is expanded. Now, as we can see here, it's not very much, the mesangial area is not very high. We have to look carefully for some eosinophilic area between the capillary loops. Now, if it is very prominent, as in IgA nephropathy or a diabetic nodular glomerulosclerosis, we have a very prominent mesangium expansion or even nodular lesions of mesangium. Now, after the mesangium, besides the mesangial expansion, we can look at the nuclei on the mesangium, and 2 to 3, I guess, is normal, but you have like 4, 5, 6 nuclei in a mesangium. We say it's mesangial hypercellularity, and that is also seen in various pathologies. So there's a basement membrane, mesangium, mesangial cells. Podocytes, are they more prominent or lifted up? And whether the lumen is occluded. So if this capillary loops which we see here are occluded, now there can be 2 ways, although there are many, but when we have an occluded capillary loop, which we see here, it can be either due to something that's lining the capillary loop, which will be more endogenous, involving the endothelium, or it will be from outside, right? So in various conditions, we have various deposits. It can be subepithelial deposits or subendothelial deposits, right? So first of all, we see if the lumen is getting occluded. If the lumen is getting occluded, it is more likely to be a subendothelial deposit, right? We are seeing that. But if it is more of a subepithelial deposit, we may see a part of what we can say the capillary loops, as in membranous nephropathy. The stiffening is there, and because of the subepithelial deposits, but the capillary loops are seen. And if the loops are gone, definitely we should think of subendothelial deposits. Fine. And that's it. It's very difficult to explain this on one go because you need some hands-on experience. when it comes to nephropathology, and even a year of fellowship is difficult to give you the best of expertise, but yet yes, determination and hard work can lead us to anywhere you want. Now moving to proximal convoluted tubules. We all are in a learning process, and none of us is done or is become the most expert person, but yes, people who keep on learning do become better and better every day. Now proximal convoluted tubules, just we look here at the normal, we have the normal brush border, which is the first thing to be lost in acute tubular necrosis. Now we have this proximal convoluted tubules have more abundant cytoplasm, which is quite granular eosinophilic cytoplasm with brush border, and we have the basement membrane, which is seen nicely here. So then we comment on the tubules whether or not there is any acute tubular necrosis or some chronic event, whether there are some protein resorption droplets or some any other significant pathology like isometric vacuolization, which we can see in CNI toxicity, calcineurin inhibitor toxicity, which is given to transplant patients. Now that is one thing. So we comment upon the glomeruli. Various pathologies are there. We look upon, if it's lupus, we will be looking for wire loop lesions, subendothelial hypercellularity, and various active as well as chronic events which we have to study in the glomeruli. Then we have membranous pattern, we have proliferative pattern, MPGN pattern. Various patterns are there. Nodular patterns are there for nodular glomerulosclerosis, monoclonal immune deposit diseases like MIDDs. Various causes are there. We look upon that. Then we move upon the tubular system, whether or not there is any, what we can say, acute tubular necrosis or some deposits or vacuolizations, etc. Right? So we have any presence of any casts. Casts we generally see in the tubules more and in cast nephropathy, which we'll see now. Then we comment upon the blood vessels. Now blood vessels are important, so we look for any amount of arteriosclerosis, which could be any amount of intimal hyperplasia, arteriosclerosis. And then finally we comment upon the interstitium. In the interstitium we look for presence of any significant amount of tubular inflammation. Now, and generally we compile and comment upon the tubules and the inflammation in the interstitium combined in a way what we call as interstitial fibrosis and tubular atrophy, which is known as IFTA. It is very significant when we interpret kidney biopsies. So fibrosis of interstitium, and as we all know, fibrosis can be best highlighted by Mason's trichrome stain, and tubular atrophy is seen as very much better in a PAS stain, which will have wrinkling of the basement membrane and many other features like that. So it's very important. So IFTA is there, and we have these arterioles, the smaller ones, the bigger arteries, and then the tubular system and the glomeruli. In this way, we first of all separately look at the compartments, and then we come to a particular diagnosis. And whenever we speak about kidney biopsies or kidney, we always have to look at the clinical picture first. Well, like if I say it's adult person with nephrotic range proteinuria, will think more of membranous and FSGS, more specifically in HIV people, HIV positive people. And if it's a kid with nephrotic range proteinuria, will think more and like of a minimal change disease, right? If it's a young person with hematuria, prominent hematuria, and even a recent history of an upper respiratory tract infection, think more of IgA nephropathy, right? So it's very important. It's to know the clinical picture. To know the clinical pathology. What's the proteinuria like? What's the creatinine, right? Blood urea nitrogen. Everything is important here. So this is a very small summary. I hope it's helpful, right? So that's it. Thank you very much.